This week's lecture will cover patient preparation. For the initiation of an examination, all CT exams must be initiated by a clinician with appropriate credentials, such as a physician, a nurse practitioner, or a physician's assistant. The order is either written or electronically entered, and then the clerical staff schedules the examination with the facility. The original order, either in written or electronic form, should be transmitted to the facility to reduce the change of error. This allows verification of the correct examination for each patient. A CPOE is a computerized physician order entry system, which is an electronic system that eliminates errors caused by legibility and translation. The technologist verifies the original order against what has been scheduled prior to performing the examination. The proper selection of exam protocol is required by the radiologist. The protocol should answer the clinician's question with the least amount of risk to the patient and include consideration of patient ability and condition. In some facilities, a radiologist reviews each individual order to direct the technologist on the particular protocol. In other facilities, the protocols are preset by the radiologist for the technologist to follow, and they may be based on clinical indications and patient criteria such as allergies and renal function. Technologists must understand the criteria to use to determine the protocol to be used. Prior to bringing the patient to the room, it should be prepared for the appropriate examination. This includes a tube warm-up, clean linen on the scan table, loading the injector, appropriate equipment attached, such as a head holder, supplies stocked in the designated location, positioning devices clean and readily available, and safety equipment such as lead aprons, collars, ready for use. An accurate medical history must be obtained by the patient to ensure patient safety, assist with protocol selection, and provide the radiologist with diagnostic information. Typically, a patient history form is used, which requests consistent and thorough information from each patient. The first step is to accurately identify the patient to be scanned. Many facilities use two identifiers for all patients, which include the name and date of birth. Hospital patients should not be identified by room number or name posted near the bed or the door of the room. Contrast media may be contraindicated in some situations. Patients must be questioned regarding renal function and allergy to determine if contrast can be used. Questions regarding hypothyroidism and other thyroid diseases may determine if the patient can receive iodinated contrast. Female patients within childbearing age must be questioned for the possibility of pregnancy. If a patient is pregnant, risk versus benefit will assist with the decision to scan or not. This discussion includes the patient, the referring physician, and the radiologist. Medical history provided by the patient assists with selection of exam protocol. The electronic or paper health records may be available to support supplemental information provided by the patient, such as lab results indicating renal function. Some questions that assist with protocol selection include symptoms. Are the symptoms new or chronic? And the onset of symptoms. Previous examinations may provide information, especially if used for comparison or reference. A medical history can assist with pinpointing the exact disease or condition, since many have similar findings. Information to assist with this include the patient's past surgeries, any significant medical issues, and current symptoms. Lab values are most frequently viewed prior to the CT exam, include a blood urea nitrogen and a serum creatinine and a GFR. These tests provide information regarding renal function to determine if contrast can be given. Normal ranges can vary among labs for men and women. For BUN, it's 7 to 25 milligrams per deciliter. For serum creatinine, it's 0.6 to 1.7 milligrams per deciliter. And policies may state not to give contrast if the BUN is greater than 30 milligrams per deciliter or if the creatinine is greater than 2 milligrams per deciliter. Some CT exams, such as biopsies, also carry the risk of bleeding. For these exams, prothrombin time, also known as PT, and or partial thromboplastin time, also known as PTT, and platelet count are used to indicate patient's clotting ability. The PT should be 11 to 14 seconds, the PTT should be 25 to 35 seconds, and the platelet count is between 150,000 and 400,000 cubic millimeters. Medications that can affect clotting include Coumadin, aspirin, heparin, and Plavix. CT technologists are responsible for providing patient education and obtaining informed consent prior to the examination. The technologist should at least describe how the procedure is done, which includes lying on the back and the table is moving, the appropriate length of time of exam, if contrast will be given or not, and if so, how many potential side effects, what is expected of the patient, such as breathing instructions or holding still, and any follow-up after the exam is completed, such as drink lots of fluids. The practice of obtaining consent is due to patient rights of what is done to their body. If consent is not provided, the technologist may be liable for battery. Basic consent involves letting the patient know what you plan to do and ask if they agree to have the procedure done. This is appropriate for most radiologic procedures. It is common for written consent to be requested if contrast material is to be given. Obtaining signed consent forms allows for documentation of the procedure and associated risks, and the goal of informed consent is to provide an opportunity to be informed about healthcare decisions and includes a discussion of the nature of the procedure, reasonable alternatives, relative risks, benefits, and uncertainties, and acceptance of intervention by the patient. For consent forms to be valid, patients must be competent to make the decision, and consent must be voluntary. Parents or guardians must sign for minor patients. Immobilization and patient restraint devices sometimes are used in CT for patient safety and to improve image quality. Straps can be used to secure a patient from falling off the table and to remind them to hold still. Bean bags prevent motion by being placed along the lower extremities. And the technologist must first explain the need for the device and then show how it will be used. Basic consent for the device is needed, and rules regarding restraints include the patient must be allowed as much mobility as safely possible. The areas of the body that are restrained should be padded to prevent injury. Normal anatomic position must be maintained. Knots that become tighter with movement are not allowed. The immobilizer must be easy to remove quickly if necessary. Circulation and/or respiration must not be hindered by the device, and if leg immobilizers are used, wrist immobilizers must also be used to prevent patient removal of leg immobilizers. The technologist assesses the patient upon first contact. They will notice breathing, skin coloration, and overall health pre-examination. The patient should then be monitored visually and verbally throughout the exam to assure quick intervention if needed. Special monitoring devices are typically not required. Unstable patients should be monitored very carefully with the assistance of a nurse or a healthcare provider. Adverse reactions are random, unpredictable signs of a problem. We must monitor vital signs to identify adverse reactions as soon as possible. Vital signs are the best indicators of a physiologic change in a patient, and they include body temperature, pulse, respirations, and blood pressure. The body temperature is the most often taken with a thermometer in the mouth, ear, axilla, or rectum. In CT, the thermometer is electronic, battery-operated with disposable covers. It can be tympanic, a disposable syringe with chemical strip, mercury-free glass. Oral, rectal, and tympanic temps are higher than axillary because of the contact with mucous membranes. Oral typically runs from 96.8 to 100.4. Rectal typically runs from 97.2 to 100.8, and axillary typically runs from 95.8 to 99.4. A pulse is the alternative expansion of our arterial wall in a given time frame. The pulse rate for adults is 60 to 100 beats per minute. For a child, it's 95 to 110 per minute, and for an infant, it's 100 to 160 per minute. It can be felt wherever a superficial artery can be held against a bone or firm tissue. The locations it's most easily felt at include the temporal, which is just anterior to the ear, the facial, which is the lower margin of the mandible, the carotid, which is the anterior neck to the right or left of the midline, the radial, which is the thumb side of the wrist, the brachial, which is the medial elbow, the femoral, which is in the groin, the popliteal, which is behind the knee, or the pedal, which is the posterior ankle or top of foot. Respirations are the breaths taken per minute. They are measured at rest, and you count the breaths for 1 solid minute. The typical respiration rate for adults is 14 to 20. For adolescent youth, it's 18 to 22. For children, it's 22 to 28. And for infants, it's 30 and higher. The ratio of respirations is 1 breath per 4 heartbeats. Blood pressure is the pressure exerted by circulating blood on the walls of the vessels, generally refers to arterial pressure. This is determined by the force and the amount of blood pumped, the size of the arteries, and the flexibility of the arteries. It is continually changing depending on activity, temperature, diet, the emotional state, posture, physical state, and medications. It is most commonly measured with a sphygmomanometer and a stethoscope, also known as oscillation, and it is measured in millimeters per mercury. The initial sound of whooshing is the systolic measurement, and when no sound is heard, the diastolic measurement is available. Systolic is the peak pressure, which is the beginning of the cardiac cycle, which is the top number, and diastolic is the lowest pressure, or the resting phase of the cardiac cycle, and the bottom number. Normal range is 120 over 80 millimeters per mercury. In summary, there are steps to the CT process prior to the exam, which include preparation of the room, order verification, patient identity verification, obtaining a medical history, explaining the exam and obtaining consent, and continually assessing the patient.